Yeah, that's a good question. When you're speaking with clinicians or procurement teams, your approach should be simple and value-driven. Every clinician and hospital is very different, and every country or region has its own particular workflow. So the key is to understand their priorities before introducing the device. Start by qualifying the prospect. Ask how many banding procedures they perform, what their current workflow looks like, and where the bottlenecks usually are. If they mention slow setup, inconsistent performance, or the time taken to reload bands, that's your opening. Because these are exactly the areas where the Haemoband delivers immediate, measurable improvements. Okay, cool. There's 4 reasons. Firstly, it's a single-use device. There's no need for equipment sterilization. And secondly, there's no loading of bands. So there's no awkward, hard-to-manage band loading as it's preloaded with 4 bands already. Thirdly, it's very fast. As the bands are preloaded, it reduces the time taken from approximately 20 minutes to less than 3 minutes per procedure. And fourthly and lastly, it's a solo operator. There is no need for a nurse assistant and is operated by one clinician with a multi-action handle controlled by one hand, leaving your other hand for your anoscope or proctoscope. There are a number of differences. Firstly, the Haemoband has pre-loaded bands. Most other devices in the market require the user to load individual bands one at a time. It has a multi-action trigger which controls both the suction and the deployment of the bands, without the need to place fingers or thumbs over the hole to create an airtight seal. There's no need to sterilize the device like you would have with some of the reusable metallic devices. It is ready to use immediately from the packaging. Our bands are individually molded from latex-free rubber, not extruded like most competitors. Extruded bands fray and weaken. Ours don't. You get a consistent strength, reliable performance every time, and a guaranteed shelf life. And there's no assembly or setup time. You can start Haemobanding immediately from the packaging. Okay, sure. Yes, rubber band ligation began as a therapy in the 1960s. It is safe, effective, and is universally used therapy, with the majority of patients experiencing significant symptom improvement and only minor temporary discomfort. Serious complications are extremely rare. Over 1 million Haemoband devices alone have been used globally since 2006, just under 20 years of safe, effective use. The device is FDA 510K CE certified and manufactured under an ISO 13485 certified quality management system here in Ireland. And furthermore, all our rubber bands are latex free. Okay, it's a 4-band preloaded tip. The tip is precision engineered with an inner and an outer section that moves seamlessly over one another. The outer section moves forwards and backwards to deploy and reload the bands in sequence, while the inner section remains stationary. It's a multi-action trigger with 3 functions. 1, induce suction. 2, band deployment. And 3, reloading of the next band. There's consistent suction. Our innovative internal mechanism creates a fully sealed system the moment you pull the trigger, delivering constant, reliable suction to the tip. And with our design, there is no thumb hole, no extra steps, and no chance of losing suction. Just consistent performance every time. Okay, this is a good question when it comes up time and time again. Normal hospital suction systems are adequate and are widely available. In the absence of such a system, small, inexpensive portable suction machines can be used and provided. Up to 600 millimeters of mercury or 0.8 bar of negative pressure is what is recommended for the procedure. However, I know clinicians using much less at 350 to 400 millimeters of mercury. It really depends on the clinician and their suction source. If the suction is low, then allow a longer sufficient time to draw in the hemorrhoidal tissue before completely pulling the trigger and deploying the band. Please don't hesitate to contact us for recommended portable suction device suppliers. No. The band material polyisoprene, a latex-free synthetic rubber, has been specifically selected to ensure that even after long periods of stretching on the preloaded tip, the band will return to virtually its original size. This reliable recoil of the band provides the consistent constriction needed to effectively cut off the blood supply to the hemorrhoidal tissue, and ultimately it then falls off a few days later. We conduct regular aging and performance testing to confirm that it consistently meets all required performance standards. Okay, this is a really good question. The surgeon has very little to actively manage. Once the endoscope or proctoscope is correctly positioned and the tip of the Haemoband is placed against the targeted tissue for ligation, with the suction set within the recommended range, the device does the rest. The tip automatically draws in the optimal amount of tissue, no more, because the chamber has a fixed maximum volume. With Haemoband, suction engages automatically as soon as the trigger is partially squeezed, removing any need for the surgeon to manually judge when to apply suction. Trigger release will automatically disconnect suction pressure, releasing the banded tissue, and will position the next band ready for the next application. The surgeon will clearly see the banded tissue. Haemoband is priced higher because it delivers more advanced features. A fully preloaded multi-band system with built-in easy-to-use suction. These innovations cost more to produce, but they give clinicians faster procedures, more consistent results, and better patient comfort. Cheaper or reusable banders lack these features and often come with hidden costs like sterilization, extra staff time, and slower workflows. So the price reflects the added engineering, convenience, and performance you get with Haemoband. If you're a distributor joining our network, we're here to support you with training, videos, and answers to every clinician's question.